Good evening, everybody. Thanks for joining us. We have a great talk planned for tonight. Dr. Elvira Lang is joining us from Massachusetts. She is kind of very well known for her use of hypnosis during medical procedures. She started out as an interventional radiologist, did some of her training at Mallinckrodt and as well as at UCSD. And then she held positions at Stanford, Iowa, and also at Beth Israel Deaconess Hospital in Massachusetts. Since that time, she's written a book on patient sedation without medication, and has also is the founder of Hypnalgesics, which is a company that basically works to train medical teams in building rapid rapport and using quick techniques to help patients tolerate procedures better. It helps to reduce anxiety as well as maybe a pain component. So we are very lucky to have her come speak with us about some of the things that she has learned over the years and will all help us in all of our practice. With that, I'd like to welcome Dr. Lang.
Great. Well, thank you very much for having me, and thank everyone for being here up and bright still in the evening. And I might even put a little pitch out for you guys. Keep doing your research, because even if it might seem at the beginning somewhat unlikely to be successful, you can make a career out of it, which is something that basically happened to me when after I had done all my biochemical research, which is a bit harder to do when you're an interventional radiologist. But when you have the chance to see what happens in clinical work and start to look more to it, you actually can create something that then maintains you even in your later years. Well, it all started at the VA in Palo Alto when there was an extremely scared young Vietnam veteran who had repeated tube changes for a intestinal drainage tube. And it took enormous amount of drugs to even get him onto the table. And that's where I saw the very first time how a very quick imagery intervention or a quick hypnotic intervention could make a difference. But then I was thinking, gee, is this gonna work for other patients too? And so I started a research program surrounding that, which over the years has been generously funded by NIH and DoD, and to the account of $3.5 million. And after we kind of completed that funding mechanism, I did set up my own company to train medical teams in what we now call Comfort Talk. And that company is now also supported by NIH in a small business innovation in research grant. So that's my pitch for keep doing your research. What I thought to start out with, I wanted to show you a little example of what falls under the whole topic of Comfort Talk, which are just some slight changes in how you might use vocabulary, in what you might say, or in what you might do. And then I will also show you some of the research results we had, how it looks in real life during a case, and then give you a little opportunity to practice and think about. So while we'll be looking at this next video, have a look about what you think the nurse could have been doing different. And it's a very common thing that happens wherever you work, like placement of an IV.
I need to start your IV for the contrast dye. You're not afraid of needles, are you? All right, you're going to feel a little bit of a pinch, followed by a prick and a little bit of a flush. It may hurt a little. Are you all set? There, that wasn't so bad. When your contrast dye goes in, you might get a metallic taste in your mouth. And if you start feeling woozy, just let the technologist know.
Okay. Since you are able to write in, it would be great to just see a little bit what you think she should have done different.
One thing I would say while people are writing in is, she did set up kind of her instrumentation, her needles right in front of the patient, and made a lot of assumptions about how the patient was feeling. She made assumptions about, oh, you're not afraid of needles, are you? And basically offered a lot of things like that. I don't know if other people have thoughts.
Well, there are already two very good points in making assumptions of how the patient's going to feel and showing all the goods up front.
One of the attendees also writes in, she really didn't have much empathy for the patient.
And I think this is always a very fascinating piece about if you now suddenly say to somebody, have more empathy. How could one do that? And the clip also shows how quickly evaluations are formed about what somebody does, how a few things form an entire gestalt. And that's how these like 360s work, or these evaluations you're getting as residents and as fellows. What you guys think about her saying, oh, it's just going to be a little pinch and a little prick? Any thoughts on these suggestions where there is going to be an upcoming stimulus, and for you to just reflect a little bit about what happens if you say, oh, it's not going to be that bad. Well, any of those things that one commonly says to make a patient feel better. So I'm just going to have you think a bit about this. And we actually ran into a lot. Oh yeah, we just have another good comment about eye contact and smile. Yeah. That she may have belittled his pain. And that's a very important point. You never know what the patient's going to feel. And when we did one clinical trial with large core breast biopsies, where the team absolutely loved to already say how it's going to sting and burn, we thought, well, we don't know it either. So we went into the procedure room and we looked at what do people say and how do people feel afterwards. So we looked at 159 tapes from interventional cases, and two research assistants checked what patients were told before local anesthetics or punctures or before contrast bolus. And pain was measured on a scale of 0 to 10, 0 none at all, 10 worst possible. And lo and behold, what happens is when you announce a painful stimulus, even if you say it's only going to be a little sting or just very short, just mentioning pain increases significantly the pain perception afterwards. And it also gets the anxiety up. If you, let's say afterwards, oh, that wasn't all that bad, it's not going to affect subsequent pain perception, but it will increase the anxiety that's lingering around. So often just not saying something or remaining pretty neutral can make a big difference. And so I'm going to show you again a little bit the prior video with the comments you made, where she kind of showed all the goods here before. And it's interesting, we assumed she didn't do eye contact because the didn't look empathic, but she actually did. But see how she behaves differently, and the things she says, like at first, which is a repeat of the same you've seen, and then how she's going to adjust it.
I need to start your IV for the contrast dye. You're not afraid of needles, are you? All right, you're going to feel a little bit of a pinch, followed by a prick and a little bit of a flush. It may hurt a little. Are you all set? There, that wasn't so bad. When your contrast dye goes in, you might get a metallic taste in your mouth. And if you start feeling woozy, just let the technologist know.
That was a good example of how not to talk to a patient in the prep room. Hello and welcome to the training support portal for Comfort Talk. I'm your comforting coach Elvira, and the topic of this video is the prep room. The prep room is important because the way a patient experiences the first potentially painful stimulus can frame their mindset for the rest of the exam. Wording that mentions pain or undesirable sensations will increase a patient's pain and anxiety. Words are the key. And now let's watch how to properly communicate with a patient in the prep room.
I'm going to start your IV now for your contrast medium. You might feel some coolness or warmth. Some people even describe a delicious sense of tingling. There, you're all set.
You're done?
I am. Please let me know if there's anything else that you need, and the technologist will be with you in a minute.
So one of the methods one can use is to offer choices between some neutral sensations, like some warm or coolness, because that gets the mind to think, well, is it the one, is it the other? And takes away the focus on a potentially painful experience. The delicious sense of tingling, that is really one of the secret weapons. If one day you're gonna have your very, very challenging patient who might question every little thing you do or falls under what is sometimes called high maintenance. If you're just going to bring that in as an option, you might feel some coolness or warmth or delicious sense of tingling. It will cut it off right there. And it's also a great way if you ever have a procedure on your own. Let's say you go to the dentist or somebody giving you local anesthetic tells you every 3 seconds it's going to sting and burn and sting and burn. And as you now know by the literature, this makes it worse. And after you explained, well, it's only going to hurt if you want it, if you mention it, and they still keep going, then I have said before to one of my doctors, well, you're all wrong. For me, it's just a delicious sense of tingling. And that also kind of shuts it off and allows you to have your own experience. Now, how did we actually gather the evidence and the claim to fame here? We thought, well, let's look at what would happen if we're going to do a very quick guidance in self-hypnotic relaxation. And since it had to be standardized, we started working with scripts very early on. And fortunately we did, and we're still using the script with some modifications. And later I'm going to read you some part of it, the way we use it. Then I felt, however, you can't just walk up to somebody who comes for an angioplasty and walks into the room, that you're going to do that unless you can get the concept of, we call it now comfort talk, very quickly across. And for that, you need advanced rapport skills. And we call that empathic attention, by putting into it a set of observable behaviors that we could track and that we can also teach. And these very quick rapport skills of empathic attention were displayed by the research assistant also in the group where we were reading the script. And what we found there is that if you bring the patient in the room at time 0, under standard of care, that's the blue line, pain goes up over time. And that's regardless of the amount of medications. We've done 2 more large randomized clinical trials, one with large core breast biopsy and one with tumor embolizations of malignant liver tumors and uterine fibroids. And the same thing, pain goes up over time. And interestingly enough, the steepness of this incline here is pretty much undistinguishable among the different patient groups. And I'm starting to believe, based on some of the work we're doing in MRI these days, that even if you just put a patient on a table and you don't do anything, you still will have this kind of physiology happening. And one of the explanations why that is the case is, based on evolution, we are all primed to always assume the worst. So imagine millions of years ago, our ancestors, perhaps out there in the savannah, and one of them may hear a sound in the grass and say, oh, not a big deal, and just keep about going what the person was doing. The other person say, oh my, it could be a tiger. Yeah, perhaps I should be doing something about it. At least turn around, watch out, or do something to protect myself. And you can see how over the years this then has led to a selection of all of us who, in case of ambiguity, rather assume the worst. And it's a protective mechanism. So if there's a stimulus and a patient doesn't know about, was that actually painful or not, the patient will interpret it as painful. There also have been studies done with psychology students who have to do this for credit, where they hooked them up to a machine where the first time lights were flashing and they got a little electric shock. And the next times there were only lights flashing but no electric shock. And these subjects actually interpreted every subsequent event as more painful as the one before. So the key thing, keep that in mind, what's happening. If you display empathic attention skills, the increase is not as steep. But if you read a script right out here in the beginning, if anything, your patient is on autopilot, or things might even get better. And the way it looks like for anxiety too, anxiety tends to go up under standard of care, hangs about around in the middle, and goes quickly down in the red line here with a few comforting words at the beginning. Now, just to give you a little sample of what are these comforting words in the beginning. And again, this is gonna be read off the script. We used to have these scripts right in the IR room, laminated so that you can clean them off. And while the patient is wheeled in and being prepped, one person starts reading. If that person is called to the phone or needs to get somewhere else, another person can continue. And it's not taking all that long. So the way this sounds is, we want you to help us to help you to learn a concentration exercise to help you get through this procedure more comfortably. It can be a way to help your body be more comfortable through the procedure and also deal with any discomfort that might come up. Just a form of concentration. By getting so caught up in a movie or a good book that you forget you're watching a movie or reading a good book, or when you're surfing the web, you don't know where the time went. And now you may be interested to learn how you can use your imagination to enter a state of focused attention and physical relaxation. If you hear sounds and noises in the room, just use those to deepen your own experience and use only suggestions that are helpful for you. And there are lots of ways to relax, but there's one simple way. And if you want, you can even follow me in that. And on one, you can do one thing, look up, and on two things. Slowly close your eyes and take a deep breath in. And on three things, breathe out, relax your eyes, and let your body float. That's right. And just imagine your whole body floating right through the table with each breath deeper and easier. And with each breath you take in strength, and with each breath out, sink calm. That's right. And just imagine that you're floating somewhere safe and comfortable, in a bath, a lake, a hot tub, or just floating in space with each breath deeper and easier. And just notice how with each breath you let a little more tension out of your body as you let your whole body float, safe and comfortable, with each breath deeper and easier. And now with your eyes closed or open, whichever state you are in, remaining in this state of concentration, just focus on how your body is feeling right now. Would you imagine yourself being? What's it like? Can you smell the air? Can you see what's around you? Good. Now this is your safe and pleasant place to be, and you can use it in a sense to play a trick on this whole procedure, and you can always return to it. Your body has to be here, but you don't. So just spend your time somewhere where you would rather be. And now, if there is some discomfort, and there might be with the procedure, whereas you feel the contrast entering your body, no point in fighting it. You can admit it, but then transform that sensation. If you feel some discomfort, you might find it helpful to make that part of your body to feel warmer, as if you were in a bath, or cooler if that's more comfortable, as if you had ice or snow on that part of your body. This warmth and coolness becomes a protective filter between you and the discomfort. And then we have some provisions in the script for if there is really need for pain management during the case. Also some provisions in the script if patients should have some worries. If somebody is really, really anxious or really worried, you have to do some reframing to get the patient in a state of mood to actually let go for that. And then pretty much you're done with it. This is all you need to do for the whole rest of the case. If on and off you say, well, that's right, that's all that's needed. And when the procedure is completed, you just say, okay, the procedure is completed now. We're going formally to leave this state of concentration by counting backwards from 3 to 1. And on 3, get ready. On 2, with your eyes closed, roll up your eyes. And on 1, let your eyes open, take a deep breath and let it out. That's the end of the formal exercise. But when you come out of it, you will still have the feeling of comfort that you felt during it. Ready? 3, 2, 1. And then you have the patient take a deep breath and instruct them to feel refreshed and very proud about having helped yourself during this procedure. Okay. I hope everybody is back in the webinar. We'll find out in a little while. So that is the script we use. It's in the Patient Sedation Without Medication book. It's also printed in a paper we wrote about large core breast biopsy. If you need the exact titles, they're all on our website, Comfort Talk, under resources and clinical trials. So the neat thing was too, in that you read the script in the beginning, and although you do it and nobody stops working, even if you were to take extra time, you're still gonna be done basically 17 minutes faster. And I think you just need to relax one person in the room, like the patient, or even if just somebody starts reading, everybody suddenly chills and the whole atmosphere in the room gets much more pleasant and people just do their work. We looked at drug use. Patients had a bell, they just rang the bell and then were given 0.5 milligram Versed and 25 mics of fentanyl for each ring of the bell, as long as they were breathing and had a blood pressure. And interestingly, in the both empathy and comfort talk group, they requested much less drugs. But the patients in the comfort talk group here were much more stable. And that's actually why I like to do it when I had my procedures. It's just much, much, much nicer when you don't have to deal with blood pressure and heart rate, like in this case, under standard of care going up and down the whole time, but you can cruise around. And I think this is where the big time savings come in, and it's the time you don't spend on things you'd rather don't spend it, because patients who want attention will get it unless you give it right off the bat. Well, in nowadays hospital environment, all administrators say they obviously very much care about how your patients are feeling, but in the end it's all about money. And even in 2002, when prices weren't as high as they are now, just reading that script in the beginning with some training that people had received for reading the script had a potential savings of $338 in the cath lab, which kind of really adds up over the day. And right now we're running a large multi-center trial in helping patients with MRI scans to get on the table and stay there. And even there we found some pretty dramatic savings in the million range for an individual site. Now I thought I'm going to show you a little bit how this actually looks in real life when somebody sits there and reads the script. We have some of these mobile transparent glass walls, which you probably should have for your nursing staff who helps you out with conscious sedation. So have a look how this pans out in real life.
It's extraordinary to watch those folks yesterday.
I'll tell you, it's very impressive if they're just pretending.
Yeah.
It's really impressive. And as we know, medical science now says hypnosis can be used in a mainstream, real way as a powerful tool to help patients reduce or refrain from pain medication, even avoid anesthesia during surgery. As we continue the special series Under the Spell, our medical editor, Dr. Tim Johnson, shows us some of the dramatic effects of hypnosis.
Hypnosis is not just for the labor room.
Just letting your whole body float through this table.
Robert Scott is having a kidney stone removed, his second, at Boston's Beth Israel Deaconess Medical Center.
Letting your body relax.
His doctor, Elvira Lang, says hypnosis reduces the need for pain medication, which often leaves the patient confused and weakened. And it works for Robert. He says with just a tiny bit of medication and hypnosis was a breeze.
How do you compare this procedure using the hypnosis to the one you had before without it?
Well, this one here, I'm much more alert afterwards, much more awake.
Robert's experience is not unusual. Dr. Lang has now published the results with 241 patients who have undergone hypnosis while having radiologic procedures.
We found three things. The procedures are more comfortable, safer, and faster. I think it's just the state of focused concentration, like you watching TV, you reading a book. So over the past years, we've done these three large trials. The one I showed you the data earlier with vascular and renal procedures, which we were very fortunate to be getting published in the Lancet. And then we looked at the same trial design in a pure outpatient setting for women having large core breast biopsies, a highly anxious group of patients. And then we thought, well, let's see if we really have fewer complications and these patients are more stable. Is this going to pan out in the tumor embolizations? In our hospital, we treated a fair number of patients with carcinoid. And as you might know, these patients can get some pretty wild fluctuations in their blood pressure. These are some of the cases where you actually can kill somebody if you're unlucky or aren't perfectly prepared to take care of things. And so we really wanted to know, are the patients more stable? And looked at parameters of modified Andrade recovery criteria, or anything that would have gotten my attention during a case, like somebody getting de novo hypertensive or hypotensive, getting vasovagal, chest pain, EKG changes, or anything for which you need to stop your procedure. And in these clinical trials, you have to have a data monitoring safety committee and report your cases every 6 months at least to see how things are going to continue. And obviously, if you are going to do a trial with patients with malignant liver metastases, some are very sick. And if anybody dies within 30 days of enrollment in a clinical trial, you are going to be in for some major paperwork with the IRB. And I remember one of our patients who had happened to be in the empathy group died nearly months later after the embolization procedure. And I remember that my concluding sentence in the IRB document was that, to my knowledge, nobody has died of empathy yet. But I did revise my opinion when we had our review after 200 patients, and we originally planned to do 300. We basically had to halt the trial because patients in the empathy group were crashing right and left. And we were stunned why the empathy condition should have this association. We had videotaped all the interventions, and what turned out is that when there were patients in the empathy group, the research assistant didn't do anything different than usual, but suddenly everybody else in the room wanted to be extra nice, walking up to the patient all the time, wanting to make conversation, stroking the patient over the head. And as I've learned from my psychology colleagues, stroking over somebody's head is belittling in their view. It reduces a patient to a childlike state. And another unfortunate realization we made over the years is that abuse is pretty rampant. And when people come into your procedure room, they're psychologically in a state. It's dark, their clothes are off, they can't move, and you are in control of them. That are very, very powerful push-button elements that can recall old abuse. And then if you touch somebody without asking, they really cannot react. So I think what happened is that people who were empathic wanted to be that, but they just didn't know what to say and how to behave. And that's something I'm being more and more fascinated by. You know, it's like on this picture we once took out of a newspaper. You know, the little guy here gets his injection and he's perfectly fine, but dad thinks, oh my, it should be terrible. And when is the time when we are transferring our emotion onto the patient? And I bet if that kid's gonna get a few more shots over the years, he's probably gonna get the message that it should be hurting. We're actually having this year at RSNA a paper out that Nadia Kadom did, where we looked exactly at this piece. If a negative affect actually is gonna lead to worse outcomes, and I can tell you it does, unfortunately. So having seen about how important the rapport is and how important it is to frame the patient's experience, we moved more and more to become very focused on word choices and on anything that doesn't take any extra time. And while in the beginning, you could have called this whole thing as the poor woman's approach to hypnosis by just reading a quick script, which was already much, much less than pretty much the professional mind-body community, or particularly mental health community, was thinking. We are now really into 80%, 90% of just looking what kind of wording people are choosing and what they're transmitting through behavior. That's what the Comfort Talk training is all about. And then to bring in some very rapid reframing if somebody is really distressed and shows up. And we pretty much tested all elements that are included in things. By the way, if you do want to listen a bit more to that script I did, there's a free app we put out, courtesy to NIH. We were able to do this on our current small business grant. This is free. Just go to the iTunes store. And by the way, there's a nice thing about confidence in if you need to take an exam. While I was still in clinical practice, we always gave that confidence induction to our residents and fellows before they were taking their boards, to just be there in a high level of confidence. So now I thought I'll give you one little thing to see with the question, what would you do? And interestingly enough, it's something we've observed before, where people say, let's say when the equipment gets close. And this is something we observed in MRI, where you may have a heavy patient and, you know, they just take one breath and they're going to be touching your equipment. But the same approach would be applicable for anything where you can have a repeating stimulus. And how would you announce that for the patient?
Mr. Clay?
Whoops. Nope, that's not that one. Sorry.
How's it going, Mr. Lewis? You look pretty snug in there. You know, I don't want you to breathe too hard, because if you do, you might get wedged in. Hey, if you do get wedged in, I got some WD-40 around someplace, so We'll get you loosened up. What's that, Mr. Lewis? What? Well, Mr. Lewis, you know, there's really no need to threaten me with violence.
That was a wonderful example of how not to talk to a large patient. Hello, and welcome to the training support portal for Comfort Talk. I'm your comforting coach, Elvira, and the topic of this video is the large patient. Large patients present some unique problems. In the MRI scanner, larger patients are often anxious or frightened when lying down. Also because the equipment or outside stimuli is actually touching them. The key thing to accomplish is integrating the stimuli into the preferred setting the patient has chosen, or to use the stimuli as a metaphor for comfort. Let's watch how to properly communicate with a large patient.
Mr. Lewis, every time you feel the equipment against your skin, just use that as a signal to go into deeper relaxation. Just use it as a warm blanket of comfort. Pardon me? You're very welcome, Mr. Lewis. I appreciate your kind words.
I thought this last example is one you really can use next time for recurrent stimuli. Let's say if you do a biopsy and you shoot the biopsy gun and it makes its clicking sound. So when I do a biopsy, I usually test the gun outside the patient and then say, and every time you hear that sound, use that as a signal to feel every time you hear the sound, use it as a signal to numb the area even further. See, because originally I give the local anesthetic and I'm going to tell patients there's going to be a sensation of coolness or there might be some tingling, but it should be getting numb very shortly. Or you might be doing a laser or anything with a recurrent stimulus. Just use that as a signal for the patient to go into even deeper relaxation or to develop even greater numbness. So that's something I thought you could test out the very next time you are going to be in the case. And again, small changes in wording make a big, big difference, and a little hypnoidal language goes a long way. I'm going to leave you here for the official part of the talk, but really want to open this now up to your questions and to your comments.
Thank you very much, Dr. Lang. That was a great talk and great introduction to kind of the idea of comfort talk. Please, I just want to encourage anybody that has questions to type in your questions through the chat box, or you can raise your hand and I can unmute your microphone. I'd like to start with a question that I had. In the context of hypnosis, you always hear that hypnosis can be a very effective tool, but the patient has to be very open to the process. And I'm curious if in your clinical trials and your studies, do you basically inform the patient what you will be doing in terms of your comfort talk or using the script prior to enrolling them in a study? I mean, are they open to the idea of kind of the hypnosis or the comfort talk prior to being agreeable to the study, or is this something that patients are randomized into, where they are either given the script or not given the script?
Well, for the clinical trials, we did randomize, and there you obviously go through the whole IRB consent. But for the regular patient now that comes in, and also let's say the clinical trials we do now, which are purely geared towards efficiency outcomes, where we test, okay, if we train a team and the team can do whatever they want to do, what are the outcomes on the patients? In those cases, people may use some of the, whatever you might want to call it, hypnoidal language or comforting language, while they basically walk the patient from the waiting room on the table. Or even if a patient has never heard about it, I basically walk to the table and might say, hey, would you like a very quick hypnosis? It works really well and we're going to read you something. Or if you don't want to use the H word, because it really isn't, I mean, where do suggestions end? Where does hypnosis start? You could say, well, you know, I would like you to learn a concentration exercise. You know, it's just like when you read a book or you watch a movie or you cruise on the internet. You may forget what's happening around you, but you know you are fully in control. If it's a movie you don't like, you turn it off. And if you don't like the email, you may walk away from your computer too. So you're fully in control. And on top of it, you have the great advantage that everybody who walks in your door is already in a hypnotic state. In the past, it was called white coat trance. Nobody, or not many people have a white coat anymore. But there is an altered state of mind where people will very, very closely listen to whatever you say. And whatever can be misunderstood will be misunderstood. So if you say, I'm going to put you down now, or I'll see you on the other side, that may be very differently interpreted by a patient in that state of mind. And I think that's why it's, in a way, so easy to do. And even one more element, if you have a patient who comes in what you would call an apprehension, where they're really frightened, they're really back in the trauma. I mean, we see that with claustrophobic patients. And I have to say, nowadays, it's PTSD, it's PTSD, it's PTSD. There's something, some experience they had before, or some thought process that really get liberated right in that setup. And that's, though, you know, they do the same thing for veterans coming back from Iraq and Afghanistan, where they walk in the office, they get them back through virtual reality or whatever, back in the trauma, and then have to get them out. You have it much easier. They're in the trauma, and you dealing with this like every day in the angio suite. They're in the trauma, but if you can reframe it while they're in there, already in a hypnotic state, it works remarkably well.
Dr. Lang, I don't know if you can see questions that other people have posed, but I'll read a few that have come in so far. One of the questions that we have from the audience is, are there any sort of quick tips or bullet points that you might be able to offer or distribute to the various departments at different people's institutions as kind of a primer? And it sounds like maybe the script is one thing that could be offered that's available through some of your publications that you've had in the past. Is that fair to say?
It's there. We got that. We got the book. We got the app. The thing, though, is it does go into behavior change. You know, there are now some outfits that have these laminated cards for nurses and for people of what to say. And it just, particularly with the whole purpose of increasing patient satisfaction, and it just doesn't work. We actually do have some data on patient satisfaction. It's, I think, mainly avoiding negative suggestions. If you just hang out a sign that says negative suggestion-free zone, it goes a long way. Unfortunately, when it comes to pain management, it goes to the core of what people have been used to do. And so, you know, when I came to the Besiswell Deaconess, I got there right after the merger of the two hospitals. And my two predecessors, who were the section chiefs then, got into midlife crisis and left. And when I took, and then they thought if they get an outsider, everybody can hate the outsider, and it will get the teams together. But what we found there is that on the one campus, nurses were giving a lot of drugs. On the other campus, not that many. And how they were attacking each other. The one that were used to give a lot of drugs would say the other ones are uncompassionate, And the ones who didn't give as many were saying the others were drug pushers. And we actually did a study to show that what determines the amount of drugs that patients get is determined by the philosophy of the institution, not the patient's needs. So even if you bring a quick tip in, but if you don't change the basic understanding of caring and what kind of human interaction produces which emotional state, it's not going to stick.
That's very interesting. Another question that we have from the audience is how much training does it take to be well-versed in comfort talk techniques?
Well, there are variations on the theme. I think we have a quick track access where we started to do an online module for online training, which actually, let me show you, you just can go to our website, where is it? Oh, I took it out. We're just go on Comfort Talk, and then under products, there is the online course, and you can look at it. There's a free sample in it. So that's one thing. And then like this Friday, we're going to do a meeting where people do online, and then they come just like for flipped classroom for 1 day intensive training, which is very much bringing that behavioral component in. What we call the deluxe training is, or the boutique training is if one really goes into an institution and trains the team, because everybody works together, and it also gets into this whole issue of how people communicate with each other. Because, you know, interventional teams are very tight-knit. We together all the time. And our chief technologist once expressed it, we are the best dysfunctional family of Boston, and probably you could use the same for where you work. It's just like, you know, you're together day and night, and you have the stress and all that. So again, it's if you really want to get down to a complete change in culture, that takes like 1 day intense training, and then we give a bit of online on-site support to implement it, and we come back for a second 8 hours. We support with web-based tools, and we now actually start to do some virtual reality training. Again, I mean, this is why I said early on, if you keep doing your research and NIH at the end rewards you with $1.5 million to play around with that and provide all these educational modules, it's a lot of fun, and you actually can do this even outside academia.
And one final question that we have is, what are the ideal training settings for such techniques? It sounds like some of the courses you offer are kind of quicker courses that are online, and then others like are more on-site within the hospital. It sounds like you're kind of more in support, or at least in terms of the way the training would be most efficacious if everyone on the team understood the behavioral changes that go along with it. Is that fair to say?
That's right. And what we do is we typically go and train a core group, because if you can't take everybody out at the same time, otherwise it comes to a screeching halt. But what I learned the very, very hard way, you gotta make sure that the people who couldn't be in the initial training have something to still feel part of it. And that's where the online pieces come in, and we have a push learning piece on it. So a web portal where they can suggest sentences of what to say, but also the people that didn't get trained, because some of them may have had some really, really good ideas, and that's where you get still everybody together.
Yeah, I think that's good advice, and it's amazing, because if you think about it, radiology really is maybe one of the few fields where this is highly applicable. You know, you have patients sitting on a radiology or a CT scanner for long periods of times, or on an interventional table where they're minimally sedated. I mean, there's really not too many other fields within medicine where this is very widely applicable. Well, with that, I'd really like to thank you very much for speaking with us tonight. We greatly appreciate it, and I think we've all learned some great tips and techniques for how to better speak with our patients to kind of help their experience be improved as well. So,
Great. Well, thank you for having me, and play a bit around with what you learned tonight, and all the very, very best wishes.
Thank you very much, Dr. Lang.